Jeremy, what about the science?
What about the science?
You're supposed to say, thank you for the huge, meaningless question. But, can you just, in 25 seconds, can you explain all of the science of cannabis?
I decided to go to my primary care doctor, and she gave me a prescription for Ambien.
I'm a discharged veteran of the United States Army, and my involvement in cannabis has kind of been a long, winding road.
We just heard from Dr. Ruchna Patel and from Roger Martin. Dr. Patel was talking about her experience in medical school when she was battling insomnia, and coincidentally enough, or not, she's now a physician specializing in cannabis because she believes in its efficacy from personal experience. Roger is a vet, as he said. He's also a former policeman, and he uses cannabis to treat insomnia and other conditions. And my point in laying all this out is that neither of them really are what we would expect to be, quote unquote, typical cannabis users. We wanted to play that audio for you to give you an idea of the kinds of people that we'll meet and the kind of experiences that we're going to talk about in the show. People who do not fit that bill necessarily, but have found that clinical cannabis has a role to play in their lives, especially when it comes to insomnia. This is HealthLab, a production of Zana Medical. I'm Seth Lorenzi.
And I'm Jeremy Cosson, Clinical Research Liaison for Zana Medical and an investigative health and science writer. Zana Medical, who is producing this show, is a guide and resource for the personalized application of cannabis medicine. So what does that mean? We demystify the often confusing world of clinical cannabis while helping guide patients through a personalized process so they can optimize their treatment and outcomes and achieve the best results.
HealthLab is presented in an episodic series format. Each series focuses on a specific condition, in this case insomnia, and then each episode breaks down that condition further through different populations, women, veterans, seniors, and through patient stories, learning how people learned how to navigate their condition and to seek treatment. At the end of this process, our goal is that you too will come away with some grasp of the questions to ask and the processes to follow. Because insomnia is a big, confusing subject, and cannabis is a huge, confusing subject. When I was younger, cannabis was one thing. It was weed. It was a drug that you bought and got wasted with. And we're relearning some very ancient wisdom in that cannabis is actually medicine as well. It obviously has a recreational, or what we like to say, an adult use component. It is enjoyable. But cannabis is also medicine, and increasingly, that's how it's used. So we're going to explore all these and other questions and try to be of some use to you in the process. Okay, let's get started. So I just want to say Jeremy is a very well-published, well-read, and admired author. He knows an awful lot about clinical cannabis. I'm the opposite of this. I know nearly nothing about clinical cannabis. So I want to start this conversation off by asking just some very top-level kind of questions. You ready?
I'm ready. Go
Okay.
ahead. Shoot.
What is insomnia?
Insomnia? Gosh, that's a good question. I was going to ask you the same question.
that would be a mistake.
No, insomnia, it's actually a pretty complex disorder. I mean, we all kind of battle insomnia from time to time, but probably what most of us are familiar with is the acute form of insomnia, which is some sort of stressor in our lives. Maybe it's stress at work or stress over finances, that sort of thing, and it causes a short-term period which we have difficulty sleeping. And that's very normal. But a very high percentage of the population also suffer from what's considered chronic insomnia. And about 10 to 15% of those people, that is the condition. For most people that have insomnia, it's usually related to another condition as well. So it's comorbid with quite a few different conditions.
Comorbid, so happening in conjunction with other problems.
Exactly.
Some people I know like to say that conditions like insomnia are the symptom, they're not the problem. Is that accurate?
Yeah, I would say more often than not, it is the symptom of another underlying issue.
Well.
And so acute insomnia, that's something that lasts a day or two, maybe 3 days or something like that. Chronic insomnia, that persists a lot longer. People with chronic insomnia, they're dealing with this 2-3 times per week for months on end. And as we'll hear from some of the guests that we have, they've been they've been dealing with it since they were kids.
Right. That actually makes me want to cut to your interview with Dr. Kim Babson. We were really excited to speak with her, and we'll hear more from her later. She leads the Substance and Anxiety Intervention Lab at the Veterans Administration. She's an expert on these subjects and many others, and I really appreciated her clear and concise kind of rundown of some of the causes of insomnia. Let's listen.
Yeah, so the model of how we understand insomnia developing is that individuals kind of have these predisposing factors. So at baseline, you might just have like an elevated risk, that might be impacted by a number of things to respond to some type of stressor with bad sleep. And then there's some type of precipitating event that occurs. So some type of elevation in stress, or, it might be an acute stressor that's happening, and then you don't sleep super well for a little while after. And then in a lot of people, that just kind of goes away. But in folks that go on to develop chronic insomnia, oftentimes there's these perpetuating factors that then maintain that insomnia to last out for a longer period. And those perpetuating factors are oftentimes behavioral things that we end up doing to try to get rid of the insomnia we're having. So it can be like, I'm going to stay in bed longer so that I can get more sleep, whereas that is actually detrimental for our sleep. And then just kind of other types of behaviors that end up kind of maintaining that problem. And then it can turn into a longer term chronic insomnia.
Right. I always think back to the example of a senior whom we'll meet later, who's 92
Lucy.
now. Lucy, thanks. Who has suffered from insomnia since she was a child.
Right.
Yeah. So
she didn't get relief until she was like 90.
Yeah. So 80 years of insomnia.
Right.
Wow. Okay. Well, with that out of the way, what about cannabis? Is cannabis a valid treatment for insomnia?
So cannabis actually, it is, when we've looked at surveys and stuff like that of people that, why do they use cannabis in the first place outside sort of just recreationally or anything like that? Very often it's like the number one or number two reported answer because it helps them with sleep.
Right.
But just because something helps somebody, alcohol will put you out too. But,
well, I mean, you mentioned cannabis being mentioned in ancient texts. Alcohol was considered a medicine as well in some societies.
Yeah, alcohol has been used as medicine in certain contexts, but alcohol has awful effects in terms of your sleep, in terms of how it impacts it. But cannabis,
I'd like to say I didn't know that from experience.
Right.
But,
it may knock you out, but the sleep quality is really, really poor.
Yeah.
Whereas cannabis, they've done quite a bit of different research, and still we need a lot more research, but it has demonstrated to be as effective, if not more effective, than a lot of the sleep medications that are available, or a lot of the things that people do take to cure their quote-unquote insomnia.
Yeah, and the sense I get is that there's a lot of medications dedicated to insomnia, and a lot of them are not great to be taking on even a medium-term basis.
Oh, absolutely. I mean, we had a conversation with Dr. Tischler and sort of brought up benzodiazepines, and he said, well, I would kind of hope in this day and age that I don't think any physician would be prescribing a benzodiazepine for sleep. And actually, that's not correct. A lot of that still is happening. I talked to quite a few people who did say, that's what I use for sleep, and that's what my doctor said that was fine.
Yeah.
And benzodiazepines, again, like prescription narcotics and stuff like that, short term, okay, but that's not something that you want to be taking.
It's not sustainable.
No.
Yeah. Okay. Well, if we're talking about safe medication and unsafe medication, is cannabis actually safe? I mean, is it something I can talk about or function under around my family?
Okay, well, let me take those questions one at a time. But your first question, is cannabis safe? Not a big fan of the word safe, because what is safe? Again, that's sort of a subjective term, and is anything 100% safe? Most things do carry risks. They're definitely accompanied by different risks and rewards. But if we do look at cannabis and compare it to other drugs, as I mentioned, benzodiazepines or other sleep medications, Ambien and stuff like that have had a lot of reported side effects.
Ambien has some incredibly bizarre side effects reported.
Incredibly bizarre side effects, yeah. So, I mean, people not remembering what they did, and they drove their car or something like that, or some of the more extreme examples.
Sleep eating being the kind of mildest sounding.
Sleep eating,
problem.
sleep driving, sleep gambling, sleep, all sorts of different things. So none of those things are
not so good.
No, they're not good, and they don't occur with cannabis. And then when we look at in terms of toxicity,
Right.
it's almost non-existent.
You can't poison yourself with it.
You can't poison yourself with cannabis. It's to take an actual toxic amount, it would be a lot of brownies.
A lot of brownies.
You would die.
A ton of brownies. Maybe literally a ton of brownies.
Literally, but you would actually die probably from the chocolate and the sugar before you would from the cannabis.
I'm sorry that I'm laughing at that.
That being
That's
said,
bad.
though, you can definitely overdose in a different sense. And
I was going to say, I'm thinking of some patient stories we heard.
Roger,
yeah, as we'll hear.
Roger had a great example,
He got
right?
some bad advice.
Roger is, he's a veteran. He's a former law enforcement officer. He was very skeptical about cannabis actually being part of a solution, but he was at sort of his wit's end because he had taken, he'd been taking Ambien, he'd been taking oxypoison, he calls it, Oxycontin,
right.
For pain, for chronic pain, and it wasn't until a physician or two had suggested he may want to give at least cannabis a shot. Consider it. And so he talked to his kids about it, and they said, maybe, it is relatively safe. So he gets his recommendation, goes to, I guess he said like a dispensary in South Lake Tahoe. And as he describes the bud tender as kind of a hippie kid, and he got some edibles and stuff like that. And there was some chocolate chip cookies here and there and some brownies. And the bud tender told him, yeah, so, try a little bit. And if it doesn't work, then take a little bit more. And if that doesn't work, take a little bit more.
Okay, I just want to point out here, we're talking about clinical cannabis, the idea of using cannabis as medicine. So imagine any other medicine prescribed as take a little bit, and then if it doesn't work, take some more.
Out of a cookie.
Thank you, a cookie.
and yeah, it is a little unconventional. And that is, I think that's actually a big reason why Zana exists in the first place, because that's not exactly how medication should be administered.
Right.
But anyway, that wasn't his story. Zana wasn't around. And so I think he ate half a cookie. I don't know how many milligrams were in it, but probably a lot more than what would be needed from a clinical dose perspective. And he didn't really feel anything after 15 minutes, which you wouldn't, because it could take 60 minutes, 90 minutes or longer. So he ended up eating some more, another 15 minutes. I think by about 45 minutes, he probably had like 2 cookies and a brownie. And then sure enough, like clockwork, an hour and a half later, he feels it.
He's not feeling good.
Oh,
what a terrible introduction to cannabis.
Not a very good introduction. And apparently he was supposed to get on a plane, I believe, as well.
Right, so exactly.
That wasn't a good first initiation.
No.
But his options were so poor, and they were recommending Suboxone to get him off of the oxypoison, that he decided to give it another shot, and he did it much. He kind of knew what to do that time, and a little trial and error, and he got it down pretty well.
Right, and as we find out, cannabis has been
a lifesaver for him.
A lifesaver.
And he says literally like a lifesaver.
Yeah. Okay, so back to insomnia.
Oh, we weren't talking about insomnia? I thought that's what we were talking about.
Sort of.
But back to insomnia.
In my question, my line of questioning.
Okay, right.
Yeah. Given how prevalent insomnia is and how common it is and how often people shrug it off, point out nearly everyone has some experience with sleeplessness, and many of us have much more experience with it than just that. But given how common it is, I feel like a lot of people shrug it off. They feel like, well, why bother dealing with it? This is just what everyone has. I can have more coffee. I can try to sleep in. Obviously, I believe it's something worth treating, but a lot of people don't. Why? So why treat it at all?
Well, guilty as charged. I've been battling insomnia I'm actually one of those people who's battled insomnia for a long, long time. And I think
Are you yawning?
Am I yawning?
Yeah, looks like you're about to yawn.
Yeah, well, I didn't really sleep last night.
Yeah,
but that was because of a plane flight delay. But no, I don't think we really appreciate how important sleep is. I certainly didn't. And, it's kind of like a badge of honor to work. And the less sleep, it's that sort of warrior mentality that we can do anything, and people will brag about how much they work and how little they sleep.
I was just going to say that. I think it's a real kind of reflex to say, oh, how are you doing? I'm so busy. You wouldn't believe how busy I am. I'm very busy. We're supposed to be running full out all the time. And so, like you say, sleep is almost a sign of weakness.
It is. It totally is. And we remember even in the political election, one of the candidates was very excited about sharing with everybody that he didn't sleep much. And it was obviously pretty true because based on the mid-morning tweets.
Twitter usage. Yeah.
Twitter usage.
Yeah. Kind of a smoking gun.
But yeah, when you, and then when I got deep into this project and really studying sleep and the importance of it, it's pretty remarkable because most people do need, there are rare exceptions, and perhaps Trump is one of those exceptions, but most people do need 7 to 9 hours of sleep. When we don't get the sleep that we need, it has a profound impact on every aspect of our life, our quality of life. It influences our emotional health, our physical health. It impacts our relationships. It impacts our memory. It impacts our learning ability.
Right.
I'm
just thinking of even the sort of the motor skills too. I think of truck drivers. I think of people who have to.
Right. Absolutely. And and people will take artificial stimulants or something like that to compensate that. But that may give you the effect of being awake, but it doesn't it doesn't repair any of the other things that sleep actually repairs.
Well, that's actually a part of the podcast I'm really excited to get to when we talk about sleep. Like, what are kind of the mechanics of sleep? Why do we even need it?
What are the phases?
Right. What is it doing for us?
Right, because we have all these distinct sleep phases, and they each perform a different function.
Right. That stuff is fascinating. Okay. So we've talked a little about insomnia.
Wait, I think I think you asked another question I forgot to answer. Oh, about taking cannabis with your family.
I didn't say taking cannabis with your family,
right,
although some families may do that.
Yeah, it would probably depend on it. If your parents grew up in the 60s, that might be an option. But no, I think it was having a conversation with your family about it.
Who was it? It's someone we interviewed who introduced her parents to clinical cannabis, and I think you asked, well, how did you introduce it? And she said, I put it in their martinis.
Wait, who was that?
I think it was Kathy, the nurse.
Oh, yeah, that's right.
Yeah, I thought that was good. And she said, no, I'm just kidding. I didn't really do that.
That's right.
But,
because that wouldn't be good because actually alcohol potentiates THC levels. So don't mix that. Just a note there, do not mix cannabis with alcohol.
Right. Okay. So we've talked a little about insomnia. We've talked a little about cannabis. I really want people to walk away from this podcast feeling like they're starting to develop a grasp on these two very big subjects. And they're starting to get some tools, and they're starting to learn that there's a process and there's a way that you can integrate cannabis into your health if you're suffering from insomnia or other conditions. What do we do? What's the way forward? How do we combine these things?
Well, I think you latched on to something important. You said the word process. And I think...
I was just reading the script, actually.
You weren't reading the script because there's no script.
Good. No, touche.
But process is it's vitally important, actually, because without process, you don't really know what's working, what is not, or how to adjust accordingly. And so that's a big central theme to the Zana program. It's a big central theme to this podcast. Rather than just kind of haphazardly trying this, trying that, trial and error. Of course, there is some trial and error, but we want to maximize the positive effects that you're looking for while minimizing any of the effects that you don't want.
Right. Awesome. Well, we're going to push on. In the next segment, we're going to hear from some patients and learn about their struggles with insomnia, how they've integrated cannabis into their treatment. For some of them, it's been effective. For some, it is not.
And that's a really important point.
Yeah, it's
not a panacea.
Right.
We're presenting a range of experiences, and people have a variety of lenses. Sometimes things work for some people. It doesn't work for everybody. And there is no magic pill, or I guess in this situation, a magic flower.
Yeah. Yeah.
Everybody's unique.
Great. Well, thanks so much, Jeremy.
Well, thank you, Seth. Hey, Seth, how are you doing today? You look a little tired.
Thank you for that. Actually, I have to admit, after spending the entire day, or actually many weeks, working on a podcast on insomnia, last night I experienced insomnia.
Well,
I was doing research.
That was my housewarming gift to you.
Yeah, right.
So I gave you my insomnia. I slept like a baby.
Do you remember what Bob Dole said after he lost 96? When he lost to Clinton.
Is this a Viagra joke?
Nice. Thank you. This podcast is not about Viagra. Bob Dole lost the election to Clinton, and someone asked him later, well, what'd you do that night? He said, I slept like a baby. I woke up crying every 10 minutes.
That's pretty good.
I thought for kind of a stiff guy, that was pretty good.
Yeah.
Anyway, okay. So you gave me your insomnia.
Yeah, that's actually a good point.
Thanks
Because
for
do
that.
babies really sleep like babies?
Like babies? Mine didn't.
They tend to wake up and cry all.
Yeah, it's pretty, well, I mean, insomnia, sleep deprivation, babies, it's all in the same bucket.
They're good at causing sleep deprivation.
Yeah, that's what I mean. Okay. I want to play some patient audio. I want to bring in some real life examples here. The first person we'll hear from is named Rhonda. She is a graphic designer here in Portland. She's about 50, and she has been struggling with insomnia for about 5 years now. Let's hear.
Of the night. Sometimes I kind of alternate. Sometimes I'll just take melatonin if I feel like I'm pretty tired anyway. Sometimes I'll do cannabis. Sometimes I'll do trazodone if I really, really have to get some sleep. And I can't really, wake up. I need that sleep. Then I'll take a trazodone, which actually works pretty well for me. So I kind of alternate. I don't like to. Yeah, I don't really want to rely too much on anything, really. Not even cannabis,
So it sounds like she's tried a bunch of things. She's taking it slow, and she's taking it kind of on the gentle side, from what I can tell. I mean, it sounds like her approach is more to use herbal and gentle methods and sort of mind work rather than drug work. What's your take on this?
Yeah, well, and it sounds like she assesses the situation, how she's feeling that night. So sometimes and I don't think that's a bad approach at all, actually. So
really,
sometimes she really needs sleep. She'll
then
take
she
trazodone,
goes to the
she'll
exactly
go to the pharmaceutical, and then melatonin. Some people it works for, and a lot of people it doesn't work for.
Yeah.
But for her, it sounds like it works.
Yeah. Cool.
I did find it interesting though that she's only had insomnia for 5 years, and she's 50.
We'll hear more from her, but my memory is that it's actually menopause related in some ways.
That's what I was thinking.
Yeah, which is very common. Okay, let's hear the next one. Next clip is Paige. Paige is a middle-aged mom. She has been struggling with insomnia at least since the birth of her kid, if not before then.
I think she's been dealing with it her whole life.
Oh, you're right.
Right.
Sorry.
And her parents had it. And
That's right. That's right.
In the family.
She also has taken what I would describe as a gentler approach to treating it, but she has yet to find real relief. Let's hear what she has to say.
I think the biggest challenge is I've really just taken the path of acceptance. It's and that's kind of what I've heard when I've talked to doctors and specialists is some people have the, proclivity kind of genetically to have insomnia, and that I'm one of those people, and it's probably going to be that way my whole life. And I look at my parents and theirs is worse. So I just kind of accept it,
It's funny. I was going to play more of this clip now, but I wanted to stop her tape right there and point out she's one of many people who in some ways throws up her hand. It's kind of interesting. She accepts that this is a component of her physiology or her
genetics,
if you will.
Genetic makeup.
But in other ways, she just accepts it as part of her life. And that's what a lot of people do. And I'm not trying to say that there's a cure for everyone, but I just caught on that for some reason, and it sparked something. What do you think?
Yeah, no, she's tried quite a few different things over the years, and ultimately, you have to either sort of come to accept it or be bitter about it. And so I think she has a good perspective on it. Would be interested because I'm not sure exactly what her methodology was exactly in terms of. So it would be interesting to see if she had more of a personalized approach and broader knowledge in terms of what may work, what may not work for her. Terms of cannabis, whether that would see any improvement. Yeah.
Curious too. Okay, let's move on.
So that's, on the one hand, that's made it easier, but that's what's challenging. I think the acceptance has been really key because the feeling that it's, a lot of it is out of my control takes the self-blame out of it. And then there's definitely in the moments where I have insomnia, which can be hours a night, that's really what I'm practicing. And that's where meditation practice has been really helpful is I'm just practicing just accepting it, doing what I can and then just resting it and seeing it as time to rest.
Well, that really makes me think of the question of each person's individual goals. She's reached a plateau that's acceptable for her. She doesn't sleep well, I would say objectively, but she's dealing with it and she accepts it. And it speaks to the idea of personalization too. I mean, everyone is different. They're going to experience sleeplessness differently. How big of an impact is it on your daytime life? And how much can actually be done with it? What do you want to get out of it? Do you want to eliminate insomnia from your life? Or do you want to just get to a place that's okay?
It's a good point, because insomnia to me is kind of like it's a good friend, and I don't know if I want to totally get rid of it. No, in all seriousness though, you mentioned personalization, and I think it's important to have realistic objectives, realistic goals, and expectations. What is sort of a range in terms of goals that you'd be happy with?
And I want to point out too that we didn't hear this part yet, but cannabis is something that Paige enjoys, but it doesn't help with insomnia.
For her, it doesn't. And it would be interesting to see how a more personalized approach would have worked.
Yeah, absolutely. Okay, so we heard from Paige and we heard from Rhonda, and they have different backstories and different experiences with insomnia for sure, but
there's definitely some parallels.
There are definitely some parallels. Yeah, exactly. Especially, I think, in their approach and their process. So I'm going to contrast that with a very different approach. This is Jessie. She's a nurse living in New Jersey. She suffered from insomnia and went a very different route. She tried a lot of pharmaceuticals before turning to cannabis. I want to point out too that she's featured in a Viceland spot that we'll link to off of this podcast. Okay, let's listen to her.
When I was her, the only thing I was taking was Xanax. And then afterwards, my PTSD started going crazy and everything started getting bad and all the pain. And I was taking, so much. Opiates around the clock, Valium around the clock. I was on high doses of Lyrica. I was taking Flexerol at night. Not really Ambien. I never did Ambien again after years ago. I don't react very well with it.
Okay, well, this is a podcast, so you can't see that Jeremy and I both raised our eyebrows to full mast as she was talking. That is a heavy load of drugs. That's a lot to be on.
Yeah, it's amazing that doctors prescribe that much of a cocktail and that's kind of acceptable.
Yeah, I mean, I think of the idea of just the interactions, the unintended kind of collisions of pharmaceuticals in your body. I mean, how long does it take to quote unquote get off of a pharmaceutical?
Well, of course, it depends on the pharmaceutical, but
right.
I haven't really talked to too many people who have been on sort of a cocktail of all these different drugs and haven't experienced significant adverse reactions.
Yeah. Well, as it turns out, cannabis does work for her, and it works really well.
Yeah, so much that, as you mentioned, she's on Vice.
She's a poster child.
Viceland. Yeah.
Okay, let's hear a little bit more. This is Dr. Ruchna Patel. She's talking about her experiences actually in med school. Interestingly enough, since then, she's become a physician specializing in the application of cannabis, because she believes so strongly in its efficacy. Let's listen.
So I came home and I read up on the medication and I decided there's no way I'm taking this. The side effects like sleepwalking and waking up feeling drugged really concerned me. So I didn't really have many options at that point in time. But had I lived in a state where I did have access to medical marijuana, I definitely would have turned to that option.
Right. So she's talking about Ambien in that case.
What's Ambien? Oh, Ambien?
Ambien. Ambien is Ambien's sister.
Gotcha. Legally, I think we're supposed to call it Ambi-Pambi.
Right, exactly. So she was kind of sent down that same route, interestingly, as a clinician in training, and decided that wasn't for her.
Yeah, she's a clinician. She read the side effects and was not...
and just said, forget it.
Forget about it.
Wow. Okay, one more. This is Roger Martin. We heard from him earlier. Again, he's an Army veteran and a former law enforcement officer as well. So by most people's standards, a fairly unconventional cannabis user.
Well, basically, the long story short is that when OxyContin first hit the market, that was a drug of choice that I was given for chronic pain. And by October 2010, I was taking 180 milligrams of that a day and 40 milligrams of Ambien to be able to sleep 1 to 2 hours at night. And so I knew that I was on a dead-end track, obviously, with that. And a doctor that I had met in the Lake Tahoe area had used another narcotic called Suboxone to actually get me off of OxyContin. And the problem was she didn't tell me I was supposed to be on Suboxone for 12 to 18 months. And having been on opiates for so long, I wanted to get off as quickly as possible. So I managed to wean myself off of Suboxone in 5.5 weeks instead of the 12 to 18 months.
Talk about hair-raising stories, too. I mean, just being shuttled from hardcore drug to hardcore drug. And really, I think only by a force of will did he get himself off Suboxone.
Yeah, it's pretty interesting or pretty crazy to think that the remedy or cure oftentimes for heroin or morphine or opioids is like another opioid, powerful one at that. And so, in his case, yeah, I don't blame him. I see why you'd want to get off of it so fast. Yeah,
and interestingly, I don't know if we referenced this earlier, but he found his way to cannabis actually on a doctor's advice, and he was reluctant, but he actually started off with an extremely negative cannabis experience, which if we haven't detailed before, we will. But he kept his hand in the game, if you will, and he tried again, and cannabis, as he describes it, is literally a lifesaver for him.
Right, exactly. And that was, talk about process and protocol.
Yeah.
That's where he didn't know what he was doing initially.
Right, exactly.
So he didn't get advice from the right person.
He didn't have valid.
Was able to do some subtle little tweaks and able to really make it work for him.
Yeah. Nice. Those are some really intense stories. I mean, I've taken pain meds, like after surgery, for instance, but I'm thinking about the idea of taking them kind of regularly just to get to sleep. That's an intense concept. And I to be honest, I had no idea that so many people have to do that or feel they have to do that.
Yeah, and it's actually really kind of baffling that doctors would prescribe prescription narcotics for a long term because, the research and the data that we have says that different drugs like OxyContin and what's the other popular one? Vicodin, stuff like that, that they work for very short-term sort of acute
I thought that was
pain.
The whole idea.
Exactly, yeah, for 90 days. But it came up a lot.
Well, isn't there also, I feel like I remember listening to a story about, actually that you forwarded me, about someone who was prescribed something, what's it called, secondary use? Someone was prescribed something that was designed for a completely different condition, but it turned out it helped treat. Do you know what I'm talking about?
Yeah. And are you talking about off-label use?
Off-label use.
Right.
What is that?
So off-label use, so many drugs, they'll go through the FDA's approval process. And to get approved for a particular condition, it costs a lot of money because those, you have to fund all those different trials.
Takes years, right?
Yeah, it can take years and years and years. So oftentimes they'll do the approval for one particular condition, but research will emerge that suggests that it's effective for other conditions. And once a drug is approved for one condition, doctors are free to prescribe that for anything.
So I'm sorry, but that strikes me as kind of insane on a couple levels. First of all, I think the approval process seems like it's a little too bulky and takes too long to get patients actual relief. If it takes drugs, 10 years to actually reach the market. But then the idea that once they're on the market, people can do whatever they want with them. So what was the point of the whole long testing and approval? If once they're on the market, you can do whatever you want. Do you know what I mean?
There's safety and there's efficacy. Right. So I think the assumption is here that they were deemed safe because they went through those trials, but the efficacy may or may not be there, but they've sort of found anecdotally, and as we know, the plural of anecdotes, not data, but many times there may have been some studies and stuff like that emerged or through just working with patients, doctors feel that a particular drug is useful for some other condition.
Or something else. Mm-hmm. Okay. It seems like personalization is a really big deal. We're going to say this again and again, but cannabis is not cannabis. There's not just one kind. There's so many kinds. There's so many different variables, and we'll get just a little bit into the chemistry or biochemistry, I guess, but there's so many different components and compounds interacting with each other. It's really complicated stuff.
Right. And how we think of, like with cannabis, it has a lot of these different compounds, and there's something that's been described as the entourage effect.
Okay.
By Dr. Ethan Rousseau, and
it's named after the program, right? The show, the
TV show. Yeah, exactly. It's your followers. No, it's more like I guess sort of described as it's these different elements, and they work together synergistically. And I think it was first characterized by Dr. Raphael Mechoulam, and then later by Dr. Ethan Rousseau, who's done quite a bit of work on how these different compounds, terpenes and the cannabinoids, how they can potentially work together in different ways and elicit different results. So that's why some strains of cannabis could be more sort of uplifting, other ones more sedative, some are more sort of cerebral, others are more sort of physical body type effects.
Well, having, let's just say, passing familiarity with street drugs, I'm aware of the indica sativa breakdown, which seemed like a kind of like a thunderbolt of knowledge. Oh, wait a second. So indica will make you sleepy, sativa will energize you. But at this point, we've moved way beyond that. I mean, those are almost consumer labels that in practice aren't that useful to us. We can go much, much deeper, right?
Right. They're much less useful to us because they actually mean a lot less now as well. Because you used to have, like historically, the way the cannabis plant was grown and everything like that, you had what was called more landrace strains.
Landrace?
Landrace, which would refer to it's unadulterated and has never been been crossbred or anything like that. So like,
so wait a second. In the wild, strains weren't naturally named Jimi Hendrix's Tears or
Green Crack,
right? they didn't arrive named like that.
No,
that's so weird.
They didn't. And so those, and really the only sort of pure, what you could really describe as an indica or a sativa would have to be a landrace strain, because most of the strains that are out there are, even if they're called an indica or called a sativa, they're all hybrids of some sort. So they're more accurately.
Well, they're designed. Would you say?
They're designed, yeah. They're designed to elicit certain effects.
You know what this makes me think of? I mean, as I'm a cook, and it makes me think of heirloom vegetables and even heirloom livestock. I did a story once on heirloom turkeys. Basically, someone had reverse bred the turkey that would have appeared on a table in the 1930s. And it was markedly different from the kind of pneumatic supermarket turkey that you buy today. Or more broadly, heirloom vegetables too. I mean, compare the tomato that you bought in the supermarket in the 80s, if you're that old, with ones you can find today that are, what would you say, single strain, an older version of the tomato before it became homogenized.
Right. And I mean, in California and certain places where we have robust agriculture, there's a lot of different choices for things like that. But there's definitely parts of the country where the tomatoes still taste like the 80s.
They're literally vintage tomatoes. It was grown in the 80s and frozen till now. Yeah. Well, so back to these patients. These approaches were really different, in my view. I mean, the people taking herbal medications or practicing meditation and mindfulness, and then the people who were on fairly heavy drugs, those are two very different approaches, but there is something in common. And I want to play one more clip from Rhonda about sleep hygiene. Of sleep hygiene. Are you familiar with that?
Mm-hmm. Yeah.
Yeah.
Yeah, and I think it's something that you kind of have to practice along with it. Like, it's not going to be, I don't think that, at least in my experience, it hasn't been a panacea, but it has helped. And I don't like the idea of taking like a heavy drug to sleep because, if it's an opiate, you can get addicted to it. It just gives you kind of a hangover. Even with valerian, I was taking valerian, and even with that, it gives you a hangover the next day a little bit.
Okay. Sleep hygiene is a concept that comes up again and again, and it's pretty important. It overarches it's more important than any specific approach to insomnia.
Sleep hygiene, it's not just showering before you go to bed. It's actually probably the first step before anything else, because if you have poor sleep hygiene, that's going to impact your sleep.
And sleep hygiene is just sort of the preparations you make in every aspect of your life to prepare properly for sleep.
Right. It's everything from improving your sleep environment to maintaining a schedule, a consistent schedule. So you don't want to go to sleep at 8 p.m. on some nights and 4 a.m. on other nights.
You never do that, do you?
No.
Last night.
Using the bed only for certain activities like sleep, being sick, sex. But other than that, you shouldn't really be in your bed watching TV or things like that.
Oh, wow. I didn't know that.
Yeah. I mean, because then you're programming your mind to think of
different activity. Well, also you mentioned TV. I mean, devices, screens. Those are a big part.
Screens are huge, and Dr. Sulak talks about that the TVs and electronic devices, those overstimulate you, and they can really impact your sleep. And a lot of people, they go to bed with their phone, they go to bed with their computer.
Oh, absolutely.
And that's probably one of the worst things that you can do to help fall asleep.
And that is so common. I mean, I use my phone as an alarm. It's near me.
Well, you can use it as an alarm, but you shouldn't be on your phone texting or on Facebook.
But I actually sleep on it. I put it under my body. Is that bad?
No, I think that works.
That's good. Okay, fine.
So on vibration or
heavy vibration. Okay, so we will get into sleep hygiene more a little bit later, but I wanted to introduce it as a kind of overarching concept. No matter what approach you try to treat insomnia, that's something you need to be aware of and a practice that you should get into.
And we've got the sleep hygiene checklist that people can download for free on the website.
Oh, that's handy.
We do.
I'm going to look at that.
Yeah.
I'm going to use it tonight, as a matter of fact.
You should use it tonight.
So to wrap up, what all these patient stories tell us is that you really need a process. I mean, again, insomnia is a big subject. Cannabis is a vast subject. And most people, myself included, could use a little guidance. There are a lot of threads to be tied together.
There are a lot of little moving pieces.
A lot of moving parts. Yeah, thank you.
Moving parts.
So let's turn our attention once more to the concept of process. How are we going to find our way through these two very complex and potentially confusing topics, insomnia and cannabis? In the third and final segment of the show, we're going to hear from some experts, clinicians, researchers, and try to synthesize a plan of attack.
Insomnia at this point is reaching epidemic proportions. So I think about 40% of the U.S. population will experience some level of clinical insomnia at some point in their life.
We just heard from Dr. Kim Babson. If you'll recall, we met her at the beginning of this episode. And what she says correlates absolutely with the stats and anecdotes. Insomnia is a huge deal in this country. It is absolutely an epidemic. So for some perspective, we turn to the subject of sleep. Do we actually need to sleep? Why is sleep so prone to disruptions? How much sleep do we actually need? To answer this last question, we turn to Dr. Nick Jikomes. He's a Harvard-educated PhD in neuroscience, and he's also the senior science advisor for Leafly. Oh, by the way, when we drop in, he's talking with Jeremy about biphasic and polyphasic sleep cycles. The idea is that you take a full night's sleep and break it up into segments so that you sleep for a while, you're awake and productive for a while, then you sleep a little more.
Yeah, there's I don't know how much of it's folklore or not, but I do remember that episode of Seinfeld where Kramer claims that Da Vinci used to do this, and so he tries to do it, and he's got all sorts of problems. The beauty of sleep is that it's so fundamental. It's just like hunger or anything else. It's homeostatically regulated, and so all you have to do because people always ask, what is the optimal amount of sleep I need? Is it 7 hours? And they want like an answer, 7.4 hours or 8 hours or whatever it is. But the answer is that everyone's different. There's biological variation, and it's built in. Like the amount of sleep so if you go to sleep, if you're tired, you should go to sleep. And the amount of sleep you need is exactly the amount you get by waking up undisturbed. So if you're waking up on your own without an alarm or any other external thing waking you up, that's exactly how much sleep you needed.
I love that example so much. I mean, the idea of all the kind of regulatory processes that our bodies are doing all the time without our being conscious of them.
Right. It's our body's natural homeostasis process.
Right. And I know your conversation with Nick also touched on the endocannabinoid system and its regulatory function with the body. I'm going to dodge that topic for the moment, but it's a topic that arises again and again. It's one of the reasons that cannabis is such a potentially powerful medicine. It works in concert with our body's main regulatory system as well.
Right, exactly. And what I found interesting too, what he said is the amount of sleep that you just naturally get undisturbed, that's what you need. But, right. Which is kind of easier said than done oftentimes. Because you fall asleep at 4 o'clock or 5 o'clock. You don't always have that choice, unfortunately.
No, as I've noticed. Okay, let's move on. We've touched on just a few of the sort of overarching concepts around sleep and insomnia, but I want to bring this back to the real world. I mean, what effect does insomnia have on our functioning? Why is that such a big deal? I'm going to cut again to Jeremy talking with Dr. Babson. Here's what they had to say.
Now, how does chronic insomnia influence or affect daytime functioning?
So that's kind of the main reason why people go into their doctor is because of the significant impact that it has on their ability to function during the day. We know that it can make people feel foggy or groggy, just kind of out of it. A lot of difficulties with concentration, with memory trouble, kind of daytime sleepiness. People might start falling asleep while they're driving or trying to do things. And a lot of negative mood impacts. Right? So feeling just kind of irritable, anxious, low mood, maybe not quite as patient for as you do when you get a good night's sleep.
So falling asleep while driving would be a negative, wouldn't it?
I was wondering actually that is there an amount of sleep that you can combine with driving that's safe, or pretty much is that a no-go?
Yeah, I'm guessing not. Well, it makes me think of some fancier cars with dashboard, these tiny monitors that actually notate your blink rate, and if it rises above a certain threshold, it alerts you. Basically, it can tell that you're falling asleep.
It's a good idea. Do they have that for? Should have that for truckers.
Yeah, well, I mean, it does exist on cars. So yeah, bicycles, skateboards.
I'm just going to go for a self-driving vehicle.
A Segway, self-driving Segway.
Segway?
Yeah,
isn't that the thing?
Yeah, the super goofy
self-driving. Like the Google cars.
Yeah, those haven't worked quite so well yet either.
Yeah, I just heard that they captured. Uber's testing them, and they caught it
in Pittsburgh,
running through in San Francisco too.
Oh, really?
Ran through a red light.
Well, that actually in San Francisco, that's normal driving. So big deal.
I guess it's adaptive to the local population.
Yeah, it's a smart car.
Right. Exactly.
But anyway, so everything we're hearing just reiterates how important sleep is and what a big deal insomnia is. It impairs our functioning on pretty much every level.
Every level.
So our takeaway from all this is you need guidance. You need a process to deal with this. We've listened to people who have tried kind of throwing treatments up on the wall to see what sticks. And some of them have found relief and some have...
The kitchen sink approach?
The kitchen sink approach. They tried everything. And in some of the cases, I'm thinking of Roger or Jesse, for instance, they had to go pretty far into a world of pharmaceuticals and low function and I think a pretty scary place.
Absolutely, yeah.
Right. Yeah. So I'm going to wrap up by hearing from just one more clinician. This is Kathy Smith. She's a nurse practicing in Maine, and she specializes in the application of clinical cannabis. And I just thought she had a really clear and concise way of talking about sleep hygiene.
It's about the process that you do to get yourself ready for bed. Like just educating people about how to get ready for sleep. It's important to turn off your phone. We shouldn't be looking at our phones in bed because that's just stimulating your brain even more. Making sure that you're consistent with bedtimes and that you haven't eaten like a big fatty meal just before bed. So some of those basic things that I would tell to any patient that's having insomnia, and just asking them, well, what have you done for insomnia? What have you tried, and have you talked to your doctor about it? So I try to make sure that they are on a healthy regimen, trying to get a healthy sleep cycle. And then we start to try to incorporate different formulations of tinctures. And
Kathy here gets into trial and error.
Which, of course, we want to minimize.
Yeah, exactly. Just the trial, please. Wait, do we want the trial?
We want the benefits.
We want the benefits. Thanks for that. But she's really talking about a process here of having really open lines of communication with your caregiver, with your physician, because cannabis is a subjective experience too. I mean, there's not one kind of cannabis. Our bodies are all different. Cannabis is different. We don't all react in the same way to the same medicine. And that's why knowing your history, knowing your lifestyle, your activities, and knowing your goals is so important. It's so personal. And let's listen to Kathy talk some more about that feedback and the trial and error process.
It's so important to have that feedback in order to know how to provide medication that's going to work for them, because it truly is trial and error. And the thing that's difficult, sometimes patients will call and say, so I hear you have the cure for cancer. And I'm like, Jesus, like, no, I'm not going to ever say that I'm going to cure your cancer.
Right. There's a lot that cannabis can do if used properly, and there's a lot that it cannot do.
Right, exactly. And I think Nick goes into that too. Cannabis can be a tool, but it's not a panacea.
Yeah, absolutely. Absolutely. Okay, so there's one last clip I want to play. This is Nick Jikomis once more. And he's talking about cannabis kind of in the spectrum of drugs. And here's what he has to say.
I would say generally, yeah. I mean, so cannabis does have some havoc-forming potential. There's a lot of people who I think romanticize things a little bit too much and say that it's non-addictive. That's not true. I don't like to think about drugs as being addictive or non-addictive in a binary way like that. I think you need to think about their habit-forming potential on a spectrum that goes from really high for something like an opioid or nicotine down to relatively low. Or to zero. Some things are completely non-habit forming, but those are typically less interesting substances. So something like cannabis is low on the habit-forming potential spectrum. Much less habit-forming than certainly an opioid or something like cocaine or nicotine. Much less than alcohol even, possibly even less than things like caffeine. And whether or not we want to tolerate something with low but non-zero abuse potential, if it does have other benefits.
Right. Like you said earlier, I mean, nothing is completely safe, quote unquote, but is this safe enough as a valid treatment for insomnia and other conditions?
Right. And I think Nick kind of echoed my statements earlier that, the word's safe, it's not a great term, but safer, and compared to a lot of these other substances, cannabis is definitely safer.
Yeah. Yeah, absolutely. So where does this leave us? We heard from patients. We heard from clinicians. We learned that insomnia is real. It's a real condition with very serious life-altering effects. Cannabis is a viable treatment for insomnia. But one of the big takeaways I got from doing the research for this podcast was that jumping in and experimenting is harder than it sounds. There's a chance you may luck out, and that's great if you do, but you really need a process. You need a way to integrate the rigor that any medicine requires in your life. We firmly believe that cannabis has an enormous amount of untapped potential for people, but it is medicine, and you need a guide.
I think you hit the nail on the head that cannabis is a viable treatment, but you don't want to just dive into it haphazardly, and process is extremely important. Understand, so that you can understand what's working, what's not, and being able to make adjustments accordingly.
Right. All right. Thanks so much, Jeremy.
Thanks, Seth.